Hello everyone. In this video, we're going to run through some key points in the pathology of uveal melanomas. Often we ask you to identify what shape the melanoma is. This is an example of a collar stud type or mushroom type shape. And it's this shape because it has burst through Bruch's membrane here and has gone into the subretinal space and potentially into the retina here. We ask you to identify the cell type. Now, the original type A and B spindle cells are out. We now just have spindle cells and epithelioid cells. In this one here, we can see cells that have got a very strong spindle shape. They're quite ovoid and have a nuclear groove. These will be spindle cells that used to be called spindle A cells, but are now just called spindle cells. Note the absence of large nucleoli. These are also spindle cells. So these in the olden times would have been called spindle B cells, but they're just spindle cells now. They have small blue nucleoli, are still ovoid and kind of seem to stream across the slide. These ones are epithelioid cells, so I think they look like fried eggs. This is the white of the egg and the yolk, and they've got this great big nucleolus. Now, it can be quite tricky because sometimes cross-cut spindle cells can look quite like epithelioid cells. Um, but the key thing is usually they have really big nuclei and a ton of pink cytoplasm. All right, how do we report uveal melanoma? We report uveal melanoma using the CAP protocol, the College of American Pathologists protocol. It is quite long. I do encourage you to click on the link and go and have a look, and then you'll understand your pathologist better. But the most important prognostic factors that we record from the CAP protocol are the tumor cell type, spindle or epithelioid, the size of the tumor in contact with the sclera. So this is the basal diameter of the tumor. Um, the extent of intraocular extension, sorry, the extent of extraocular extension, tumor location, particularly ciliary body, and whether there are extravascular matrix patterns and a high microvascular density. We'll come on to that in a moment. And then, of course, there's the immunohistochemistry of BAP1 and PRAME that has largely replaced the FISH testing. So what is an extravascular matrix pattern? What we look for are these vascular loops. So we can see them on H&E. We can do a PAS to find them. We can do clever immunohistochemical stains. But the most important thing is the vessels are very proliferative and they are growing to form these circles. Note also that this is an epithelioid melanoma. We can see some great epithelioid cells here and some smaller epithelioid cells here, but they don't have that streaming look of spindle cells. All right. So often asked to stage a tumor. The biggest thing we've got to do is measure the base and the height. That's pretty straightforward. You can estimate this from your knowledge that the globe is generally about 24 millimeters long, but I don't think you're going to be asked to stage it on the fly in an MCQ exam. Here are some tricks. If we're looking for spread down scleral nerves and veins, the other pigmented cell that's around is the macrophage. So don't be fooled by macrophages. Look at the nucleus. Does it look like the nucleus of a melanoma cell? Look carefully at the trabecular meshwork. Again, it can get pigment in it and macrophages in it, but look for those tumor cells. The ciliary body. So you'll need to know the anatomic start and stop of the ciliary body. It's got some muscle in it. That's really helpful. Look at the iris for neovascularization. This can also affect outcome. And look carefully at the optic nerves and meninges. And remember, where we want to determine whether cells are prelaminar, intralaminar, and post-laminar. And melanomas can like sneak down the side and into those meninges directly. Okay, so here we go. So it's always good to start at low power and look for prognostic factors. So in this slide here, we can see that we have this tumor. All right, we can see the tumor extends outside the sclera and into the probably the subconjunctival connective tissue here. That means that it's probably spread through a channel through here. We can see that it involves the ciliary body and probably the iris root. And we're going to be very, very suspicious that the trabecular meshwork is going to be involved. So looking at the shape of it, it's kind of still an ovoid shape here. We can see some areas of either necrosis or bleeding here. Looking at grossly, we can't see any involvement of the optic nerve. Other things here is we've got some peripheral cystoid change, a lens, and something strange has happened to this iris. That's probably due to this being put in a too small pottle to send to the lab. Okay, so looking more closely here at this one, this is an H&E, and we can see that there are vascular loops. It is an epithelioid meningioma with quite light pigmentation. These are the pigmented macrophages that often line up against these vascular channels and are easy to mistake at low power for tumor cells. We sometimes call them melanophages. And the nuclei, well, they're kind of small if you can see them, but they're definitely not these epithelioid ones. So here we go. Here's another one. So this is a trick for young players, okay? Don't assume that everything that exists in the choroid in an adult is going to be a melanoma. Okay, so we can see here at low power, we've got this tumor in the choroid. It is ovoid. It has not gone through Bruch's membrane. All the other structures are probably normal. But when we look at it here, we can see that it's forming glands. Now, this is a trick because we still have these pigmented cells from the choroid and it's disrupting them and causing inflammation. So we're getting melanophages. So what are the prognostic feature? Well, the prognostic feature is this metastatic carcinoma here in the in the choroid. The prognostic features belong to the tumor that it originated from. Like this looks quite like a breast tumor to me. So its prognostic features are to do with its stage and its receptors. Okay, here we go. Let's have a look at this one here. This is a very, very distorted globe. There is a tumor at the back. We know anteriorly, we can see that the angles are open and the lens is looking okay, and the ciliary bodies, they aren't involved. There is a subretinal exudate here. This is not a prognostic factor, but it's good to describe. Coming to the tumor, we can see it's got this kind of collar stud appearance again, where we've burst through Bruch's membrane here, and it may or may not involve the surface of the retina here. But worryingly, it's sited over the optic nerve, and we can see that there is probably early invasion of the optic nerve here. So this is a close-up of the optic nerve, the lamina cribrosa here, and this is the tumor. We're getting the impression it might be a spindle cell tumor because we've kind of got slightly streaming areas here. But most importantly, this is the lamina cribrosa, and this is the post-laminar optic nerve, and we can see that we have intralaminar invasion. If we look at it really closely, this confirms it. We can see that here, that the lamina, of course, has got these horizontal collagen bundles, which is why it looks like that. And we can see the lamina ends here along with the tumor. Hang on. This might be a mixed one because there are some epithelioid cells. So we've got a mixed melanoma. Let's just go back to the low power. So the basal diameter, by the way, is measured here. So we often use a computer to measure it now. And the height of the tumor is measured at the greatest height when we're measuring tumor stage. All right, so here's another pigmented thing. This is another trick. Here we have the cornea. It's looking a bit raggedy, and we've got the iris and ciliary body, and here we've got a pigmented tumor. So this is a pigmented tumor arising from the pigmented epithelium of the iris and ciliary body. Um, we would have to know how it was behaving and do some more tests on it to determine whether this was a pigmented epithelial adenoma or carcinoma. But another tumor that's pigmented, that is not a melanoma. Okay, here we go. So we've got another tumor here. We've got here we have the again displaced lens, anterior chamber. This doesn't seem to be affected, but here we've got a melanoma again affecting the ciliary body and iris, and we wonder what's happening here as it passes through. The optic nerve isn't involved. So as we look here at low power, we can see this, apologies for slightly out of focus photo, where we have the sclera, and we can see it's probably extending by direct extension into the sclera, but has not gone through here. And these little pigmented areas could well be macrophages around the vessels. We're looking at low power here. I guess we've definitely got invasion into the sclera through here. We can see sclera up to here, and this suggests that this is pushing invasion as well. And we still can't tell whether these are macrophages, but they probably are. All right, so let's have a look at the prognostic features in this one. We've got another eye with a slightly displaced lens. What else is going on here? All right. So the iris looks a bit flat, so we suspect neovascularization. Certainly it looks pushed down here, but there may or may not be neovascularization at low power. We can see that the tumor is still ovoid, though it has a really, really big basal diameter and a really large height. So this will affect the stage. So the most important prognostic factors here are probably the tumor size. It has not invaded the optic nerve. All right, so what are the prognostic features here? So we've got a picture of the type of cells. There's a whole lot of spindle cells here. So we have to ask ourselves, are there any cells that are the epithelioid fried egg cells? And the answer is no, I don't think so. These nuclei in these cells with slightly pink cytoplasm, they are about the same size as the spindle cell nuclei. So I think this is a spindle cell melanoma. Okay, we are going to practice some MCQs now. So the important thing with MCQs is you cover up the answers before you actually answer the question. Okay, so we know that poor survival rates are related to all the prognostic factors that we've been delivering, with the stage being more important. And as we look here, the tumor height is the stage, and that is the most important. If we look here, we've got a 33-year-old man, pigmented iris lesion. What reliably differentiates nevus from melanoma? Now, iris pigmented tumors, they can be really tricky because the melanomas look really bland. And so the most important thing is probably documented growth, okay? Because if it's a small size melanoma versus a small size nevus, we have difficulty telling the difference. All right, a 70-year-old man, new photopsia, has a pigmented lesion on the choroid. What finding strongly supports choroidal melanoma? So the answer here is the collar stud shape. Stable old photos, of course, would be probably a nevus. I'm not sure the color has anything to do with it. And we can get regression, but this collar stud shape is showing growth, which is what we are looking for in melanomas. All right, flat brown choroidal nevus. Sorry, flat brown choroidal lesion. What feature suggests choroidal nevus rather than melanoma? Okay, this is a bit tricky. So this would suggest melanoma. This would suggest This would suggest that it was thick and maybe aggressive, nevi are usually quite flat. So it's going to be either A or B. Have a think about this one. It's quite tricky. You might have had to look this up. The answer is overlying drusen. Okay, so um, the drusen will be there for a long time. The nevus will be quite stable, and this is one of the indications for it. All right, what feature distinguishes ciliary body melanoma from iris tumor? Okay, so one of the things, we often have to decide whether this is an iris melanoma. Well, actually, not that often because they're not that common. Versus ciliary body. Both will have feeder vessels, both will have angle narrowing, both will have pigment, but the iris tumor tends to have annular growth. Okay, let's have a wee look at genetic abnormalities. So in the olden days, we did fish. We looked at chromosome 3, 6, and 8, where monosomy 3 is a very bad prognostic factor and gain of 6p is a good prognostic factor. And you didn't get them together, so that there are two mutually exclusive pathways for development, one that loses 3 chromosome 3 and one that gains 6p. All right. So we also know that if it is a 6p tumor, if there's also an 8q, this is a bad feature, but these aren't what we do these days. We now just do IHC for BAP and PRAME. Let's think about the principles of FISH before we move on. So the principles of FISH are that there is a tumor karyotype, and we can detect specific aspects of that karyotype by fluorescently labeling certain chromosomes, which we do here. So here we have 4 blobs of red. This will be a comparison chromosome marker. And we've got 2 blobs of green. So if this is, for example, 8, we might have 4 copies of 8 and 2 copies of 3. And we look at the ratio between them because this could be a cell that is like 2 cells together or has doubled its chromosome. So here, for example, we've got lots of 8 and 2 copies of 3. And the same here. And they look at lots of these cells. Let's have a look here. Oh, yep. So maybe I got this one mixed up. All right, just ignore what I said here. All right, so this one here, 3 is labeled. Oh no, that's right. Sorry, 3 is labeled with green and 8 is labeled with red. So we've got lots more 8 and not much green. Before we also move on, let's have a think about these two pathways. So people have represented this in different ways. So we've got a melanoma cell, and there is a foundational mutation. So the foundational mutation allows it to proliferate in a limited way and form a nevus. Sometimes it just skips this step. And then once the GNAC mutation has happened, it can go down one of these pathways. And by looking at BAP1, which is on chromosome 3, we can determine just by immunohistochemistry, which is fast and cheap, whether this is going to be a well or a poorly performing melanoma. And of course, they then gain lots of other mutations. And in old literature, you might see class 1 and class 2 melanomas, and it's mainly depending on whether it is got chromosome 3 or not. So BAP is BRCA-associated protein. The BRCA gene is one of the guardians of the genome. And so if it is not working, i.e. lost, then of course the chromosomes become much more unstable. They're more likely to gain further mutations and metastasize, and that's why they do badly. So this is also what we would have known in the past, right? 2020, was here. So we can divide them into the old class 1, does okay, and the class 2 that has one copy of chromosome 3 or a normal copy of chromosome 2 here. And depending on their uh, particular arrangement of chromosomes, we can work out what metastatic potential they have. But now we know that if there's BAP1 mutation, they have a high metastatic potential. And I've given you a link to read about it. Let's look at BAP and PRAME, BRCA-associated protein, which gives rise to genetic instability, and this PRAME. So PRAME is protein-associated melanoma. It's the protein PR associated melanoma, MEIHC. Okay, so PRAME doesn't particularly relate to a gene, but it has been shown that in uveal melanomas, if PRAME is present, it is bad. So we've got two things here. If BAP1 is lost, it's bad. And if PRAME is positive, it's bad. So these are the well-behaved tumours where we have BAP1 preserved and PRAME1 is negative. These are the badly behaving tumours where BAP1 is lost and PRAME is positive. And then we've got a couple of combos. Okay, one with BAP1 present and PRAME present. So PRAME's doing its bad thing, but BAP1 isn't altered. And it's always worse to have a loss of BAP1. Okay, so the previous slide is metastasis-free survival, and the disease-specific survival shows exactly the same thing. BAP1 loss is bad. If it's combined with PRAME, we have even worse outcome. BAP1 positive has better outcome. If the PRAME's abnormal, it's not quite as good. Let's have a look at some immuno. All right. So BAP1 is present in normal cells. All good. So in this tumor here, we've got some normal cells, which are lymphocytes. Here we go. And it's been lost. In this tumor here, we can see that these are not being painted brown anymore. They're still blue. This large blobby stuff, that's the melanin. Okay, and all these cells have lost their BAP, except maybe for this endothelial cell here. And this is what it looks like. This is a spindle cell melanoma where BAP is preserved. So this is the pathologist's job to tell you whether BAP is present or lost. All right, let's think of PRAME. PRAME is absent in normal cells. So this is a melanoma where PRAME is expressed. Okay, and it is going to be behaving badly. These are melanomas where PRAME is absent, and they're going to be behaving well. There are some tumours which partially express PRAME, and we have guidelines to determine whether we call these positive or negative, and we will write about this in our reports. All right, so here are some MCQs that you might encounter. A 57 year-old tumor shows PRAME positivity. What does this suggest? It suggests that the tumor is more likely to metastasize and the patient will have a shorter disease-specific survival. A 55-year-old woman presents with a small choroidal melanoma. What mutation commonly initiates uveal melanoma? That is GNEC. Remember, BRAF is about conjunctival and skin melanomas, and GNEC is about uveal melanomas. All right, a 63-year-old man has a rapidly enlarging choroidal melanoma. What mutation most commonly predicts early metastasis? That is loss of chromosome 3, monosomy 3, indicated also by loss of BAP1. Here are some more MCQs. 49-year-old, large pigmented lesion. What genetic finding correlates with the poorest outcome? Of course, you're all going to know about BAP1 now. All right. So here's just an area for discussion at the moment. Most melanomas are diagnosed in situ by you guys, and small melanomas are treated in situ. We know that genetics and IHC are important in the diagnosis. When should an ophthalmologist perform a uveal melanoma biopsy? Yay, there are guidelines. You can read them here and link to them here. So there are advantages and relative disadvantages of um, having a biopsy. You can pause the video here and have a wee look at this slide. And so you need to discuss this with patients. So it depends whether the patient wants prognosis, tailored follow-up, an adjuvant trial. They should understand the risks and benefits of the biopsy. And you need to work out whether they can live with uncertainty or want a better prognosis for their better idea of prognosis for their small melanoma. And that is the end of the talk. Thank you.